Bismillah ar-Rahman ar-Rahim. Normal physiological changes of pregnancy. Elevated serum progesterone levels stimulate the respiratory drive and lead to an increased tidal volume and raised minute ventilation, with only a modest increase in auto consumption, and the subsequent fall in maternal PCO2 facilitates fetal CO2 transfer across the placenta. That's why any cause of maternal hypercapnia leads quickly to fetal respiratory acidosis. Respiratory rate is unaffected by pregnancy. Elevation of the diaphragm occurs due to the enlarged uterus, leading to reduced functional residual capacity (FRC), although the diaphragm function is normal and the vital capacity is unaffected. Peak flow and FEV1 are unaffected by pregnancy. So quickly you can summarize the affected parameters. There is reduced functional residual capacity, FRC, although diaphragm function is normal. Vital capacity and FEV1 and the peak flow are unaffected by pregnancy. Increased cardiac output occurs due to an increase in heart rate by about 15 beats per minute and stroke volume. Peripheral resistance falls. Blood pressure is reduced in the first and second trimester by 10 to 20 mm mercury, but is normal at term. Peripheral pulses tend to be increased in volume. Dependent edema is common, and third, heart sound and ejection systolic murmurs are commonly heard. May hear venous hums in the neck. Raised levels of coagulation factors and impaired fibrinolysis combined with venous stasis results in a significantly increased risk of venous thromboembolism. Upper airway edema, particularly in the setting of preeclampsia, may predispose to upper airway obstruction during sleep, but rarely frank obstructive sleep apnea. Obstructive sleep apnea tends to occur in obese women and may be associated with impaired fetal growth and preeclampsia. Snoring in the pregnancy is a poor predictor of obstructive sleep apnea. What are the causes of breathlessness in pregnancy? Causes of breathlessness in pregnancy include the following: pulmonary causes, pleural causes, vascular causes, cardiac causes, and others. Pulmonary causes include exacerbation of pre-existing lung disease such as asthma, cystic fibrosis, LAM, lymphangioliomatosis, pneumonia, bacterial including tuberculosis or aspiration pneumonia, viral particularly varicella and influenza, fungal particularly oculomycosis, aspiration pneumonitis, pulmonary metastasis from choriocarcinoma, which is very rare, and the pleural causes include pneumothorax, particularly during labor, small asymptomatic effusions postpartum, ovarian hyperstimulation syndrome. The vascular causes of breathlessness in pregnancy include venous thromboembolism, amniotic fluid embolism, air embolism, aortic dissection, pulmonary hypertension, cardiogenic pulmonary edema, exacerbation of pre-existing cardiac disease, such as valvular or congenital disease, peripartum cardiomyopathy. Other causes of breathlessness in pregnancy include non-cardiogenic pulmonary edema, iatrogenic fluid overload, or tocolytic therapy used to inhibit uterine contraction in preterm labor, acute respiratory distress syndrome due to preeclampsia, sepsis, massive hemorrhage, amniotic fluid embolism. Other causes include anemia, esophageal rupture, and hemidiaphragm rupture. Investigations to diagnose the cause of breathlessness in pregnancy include doing ABG, and ABG normal maternal PO2 is more than 13.3 kPa and PCO2 3.7 to 4.3 kPa. A compensatory fall in serum bicarb to 18 to 22 millimole per liter occurs, resulting in an average of pH of 7.44. And during the third trimester, perform ABGs is in an upright position, as PO2 may be 2 kPa lower when supine. AE gradient is unaffected during pregnancy, except when supine near term. Blood tests in normal pregnancy: white blood count, platelets, ESR, D dimers, and fibrinogen are usually raised, and the serum creatinine levels reduced. D dimer is increased from about 6 weeks gestation to 3 months postpartum, and C reactive protein is not significantly affected. Brain natriuretic peptide levels are not affected by pregnancy itself and so elevated, and BNP may be a useful pointer towards a cardiac cause. A chest radiograph, chest X-ray, may show increased pulmonary vascular markings due to normal increase in cardiac output and required for diagnosis of pneumonia and pneumothorax with abdominal shielding. The radiation doses to mother and baby are very small, and the chest X-ray should be performed if clinically indicated, and we should use abdominal shield. Lateral chest X-ray carries a greater radiation exposure and should be avoided. Further investigation to exclude pulmonary embolism should be guided by local policy in the hospital. Leg vein ultrasound should be performed first if there are symptoms and signs of a deep venous thrombosis, DVT. If DVT is confirmed in the setting of clinical features suggestive of PE, then treatment can continue without the need of radiation exposure from the further imaging. And the ventilation perfusion scans are associated with a higher radiation dose to the fetus, and as such, a slightly higher risk of childhood cancer, whereas computed tomographic pulmonary angiogram CTPA carries a greater maternal radiation dose, and in the setting of hormonal changes within the breast during pregnancy lead to an increased lifetime risk of breast cancer in the mother. The ventilation component of a VQ scan can often be omitted during pregnancy, reducing the radiation dose. CTPA should be performed if chest X-ray is abnormal and BE suspected. CTPA can also identify other pathologies such as aortic dissection in hemodynamically unstable pregnant. That's all. Thank you.